So good day. Again, welcome to Clinical Pharmacy and Pharmacotherapeutics 2, Gastrointestinal System Therapeutics. So before we start the discussion for this topic, again, our disclosure and disclaimer. This presentation is for pharmacy educational purposes only. Some slides, presentations were taken from the teaching slides of associations, organizations establishing therapeutic guidelines. Any brands, proprietary products, devices mentioned in this presentation is not sponsored nor has intentions for commercial purposes. The lecturer is not affiliated to any pharmaceutical company or sponsors. Learners are also encouraged to perform their own assessment, research, and evaluation on the information discussed in this presentation. Further, this lecture is not a substitute to any direct clinical judgment. So, for this particular discussion, we are going to focus with diarrhea. Diarrhea is basically defined as an increased frequency and decreased consistency of the fecal discharge as compared with an individual's normal bowel pattern. It is often a symptom of a systemic disease. There are three most common forms of diarrhea. We have acute diarrhea, which is usually characterized as a diarrhea that is shorter than 14 days of duration. Persistent diarrhea, as longer than 14 days rather, is considered a persistent diarrhea. And if it's a chronic diarrhea, it is considered to be longer than 30 days duration. Most cases of acute diarrhea are caused by infections, either caused by virus, bacteria, or protozoa. Generally, they are self-limited. However, if a person is immunocompromised or if the person is in the special population, such as children or the geriatric population, careful assessment and monitoring should be done in the event of diarrhea. So for the pathophysiology of diarrhea, so basically it is an imbalance in the absorption and secretion of water and electrolytes. So it may be associated with a specific disease of the gastrointestinal tract or with a disease outside the GI tract. So if you can remember, similar to our discussion in constipation, so diarrhea can be factorial to diarrhea are conditions that can affect the GI tract or other conditions that may trigger the effect of diarrhea. So there are four general pathophysiologic mechanisms that basically disrupts the water and electrolyte balance. That basically leads to diarrhea. So one of which is a change in the active iron transport by either decreasing sodium absorption or increasing chloride secretion. Another is if there is a change in intestinal motility. So as we expect, there would be an increase in the intestinal motility, leading to diarrhea. Another is an increase in luminal osmolarity. And the fourth one is an increase in tissue hydrostatic pressure. So these four mechanisms are related to clinical diarrheal groups such as what we call the secretory, osmotic, exudative, and the altered intestinal transit. So when we talk about secretory diarrhea, it usually occurs when there is a stimulating substance, such as, for example, vasoactive intestinal peptides or VIP, if the patient took laxatives, or in the presence of bacterial toxins. So these substances increases the secretion or decreases absorption of large amount of water and electrolytes. For the inflammatory diseases of the GI tract, it can cause normally exudative diarrhea by producing or um, by stimulating the discharge of mucose, proteins, and even blood into the gut. With altered intestinal transit, on the other hand, intestinal motility is altered either by reduced contact time in the small intestine or premature emptying of the colon, or if there is bacterial overgrowth. Now, this is a summary of the clinical presentation of diarrhea. So, as I've mentioned, most acute diarrhea is self-limiting and they normally subside within 72 hours. Again, however, if we are dealing with infants, young children, the elderly or the geriatric, and the debilitated persons who are quite risk for morbid and mortal events, um, prolonged or voluminous diarrhea can be expected. So generally, the signs and symptoms that we can observe is there is an abrupt onset of nausea, vomiting, abdominal pain, headache, fever, chills, and malaise. Normally, we would encounter the signs and symptoms if the diarrhea is attributed to viral, bacterial, or protozoal. Now, bowel movements are frequent and never bloody, and diarrhea lasts 12 to 60 hours. Intermittent periumbilical or lower right quadrant pain with cramps and audible bowel sounds is characteristic of small intestinal disease. When pain is present in the large intestinal diarrhea, it is a gripping, aching sensation with tenesmus or yung straining, ineffective, and painful stooling. Pain localizes to the hypogastric region, right or left lower quadrant, or the sacral region. Now, if we're talking about chronic diarrhea, there should be history of previous bouts. Patient is observed to have weight loss due to the excessive diarrhea, anorexia, and chronic weakness are important findings. Now, for drugs causing diarrhea, of course, one of the top causes would be laxatives because of their mechanism. So that's the same reason why we would like to prevent excessive use of laxatives. Now, we can also have antacids containing magnesium. I have mentioned this in our constipation discussion. Remember that aluminum carbonate is associated in constipation and magnesium is associated with diarrhea. That's why it is a logical combination in some of our antacids to combine the aluminum and magnesium. Antineoplastics, basically due to their non-selective effect, especially when the site of or the target site would be the gastrointestinal tract. We have auranofin or the gold salt. So usually these are treatment for arthritis. Antibiotics are also known to cause diarrhea. So like for example, tetracyclines, they are known to be gastric irritants. Um, some of the few options that we can have for antibiotics that have less diarrhea effects for tetracycline, its member groups such as doxycycline and minocycline. So in some cases, what we do is that we advise the patient or to take the medication or the antibiotics with food or after meals so as to decrease the effect of diarrhea. So we can also observe diarrhea from clindamycin, sulfonamides, um, other drugs such as iron preparations. So they are also gastric irritants. So that's why you can remember if we advise patients to take iron, although it is advisable that the stomach should be acidic, so we can maximize the absorption of iron. But since these are also gastric irritants, our option is to give them after meals or to use dosage forms that has gastroprotective designs. We also have antihypertensives in the form of reserpine, guanetidine, methyl-dopa, guanabens, guanadril are our ACE inhibitors. For the cholinergic, betanicol and neostigmine. For cardiac agents, mga antiarrhythmics and drugs for mga inotropics, we have quinidine, digitalis, and digoxin. NSAIDs or NSAIDs. We have misoprostol. So misoprostol is a cytotec. Okay, so it's a muscarinic drug. We have colchicine, which is a drug for gout, proton pump inhibitors, and H2 receptor blockers. So these two last drugs are medications for peptic ulcer or GERD. For physical examination, typically hyperperistalsis is observed with borborygmi or the sounds in the bowel and generalized or local tenderness. So we also should note the signs and symptoms that we have mentioned a while ago. Now, for the laboratory test, normally we do have stool analysis. So, stool analysis is to confirm if there are presence of microorganisms, blood, mucose, fats, because some conditions can also lead to diarrhea. Like, for example, if a person had undergone chole, cholecyst, no, if you have cholelithiasis and then the gallbladder is removed, so normally patients without gallbladder would initially experience diarrhea whenever they take in food or anything that is oily. So those are also things that we have to consider. So osmolality, pH, electrolyte levels, and mineral concentration. Cultures are also done to be more specific on the microorganism that might be um, the cause of the diarrhea. Stool test kits are useful for detecting GI viruses, particularly rotavirus. Now, if I may share with you, in veterinary, we do have standard kits for that. Like, for example, conditions that causes diarrhea, such as parvovirus, wherein we take swabs of the fecal samples and then we place it into the kit, and that would identify the presence of the virus. And that virus targets the small intestine, especially in puppies. And that's why it's quite deadly, for them. Moving on, we have also antibody serologic testing. Um, what we have to look at here is the titer, no, the period from which titers are raised. So it's around 3 to 6 days in period. This is practical but non-specific. We also have total daily stool volume determination, direct endoscopic visualization and biopsy. Should there be a consideration of possible colitis or colon inflammation or cancer? And radiographic studies are also helpful for neoplastic and inflammatory conditions. So for the goals of treatment, number one is we manage the diet. So since there would be excessive water and electrolyte loss, our target is to prevent those losses. And of course, to balance the acid-base disturbances, because these factors contribute to the severity or chronicity of the diarrhea. Next is to provide symptomatic relief. Of course, some patients would encounter pain, some patients would encounter other signs and symptoms, so it would be palliative in nature. Treat curable causes of diarrhea. Commonly, these are those related to bacterial and protozoal, because as long as we do not eradicate those microorganisms, the diarrhea would continue. And then manage secondary disorders causing diarrhea. So similar to the standpoint treatment for constipation, no, if it's relative to another disease. Now, what we have to take note is diarrhea is similar to cough, which is basically they act as body defense mechanism for our body to get rid of harmful substances. So the best approach or therapeutic response is not necessary to stop. No, as you can see in the goals of treatment, we do not direct the goal as to stopping diarrhea, because the intention is we would like to have those causative agents or those etiologies causing the symptoms to be eliminated from the body. However, that would be contrary if the diarrhea is secondary. Okay, so we need to control as well the primary condition in order to address the secondary diarrhea. Now, this is a standard treatment guideline for diarrhea. So first, we need to perform, once there is a presence of diarrhea, we need to perform a complete physical and history examination of the patient. So we need to identify here if the diarrhea is acute, as we have mentioned, if it's less than 3 days, then if it's chronic diarrhea or if it's persistent diarrhea. Now, if it's an acute diarrhea, we have to check if there is presence of fever or other systemic symptoms. So, if such a case, so whatever would be the positive symptoms, we can provide number one, fluid and electrolyte replacement. So since we know that there is continuous water and electrolyte losses in the presence of diarrhea, loperamide, diphenoxylate, or absorbent, usually they are being used to temporarily stop the diarrhea symptoms, especially if the patient is, like, for example, um, in a place wherein it will not be suitable, or they don't have access to the CR or the comfort room. Another is we provide them this treatment as to lessen the episodes of diarrhea. But then again, we go back to the idea that as long as there are no dehydration yet, we can still tolerate the presence of diarrhea, but we have to replace the electrolytes and fluids. And then, of course, diet should be checked, especially if diet is one of the causes for having the diarrhea. Now, if there is fever or symptomatic, systemic symptoms rather, we can check for the feces sample for WBC, RBC, ova, and parasites. So, because we would like to know if this is in microorganism in nature. If the test is negative, we still perform symptomatic therapy as mentioned a while ago. And if it's positive, of course, appropriate antibiotics and symptomatic therapy should be initiated. Remember that antibiotic use should be prescribed by a physician, and we are not advised to use antibiotics on our own selection. So if it's chronic diarrhea, so it's lasting more than 14 days, so these are the possible causes that we can consider. Now, of course, part of which to narrow down the choices or the selection for the causes, we need to perform the history and physical examination. Now, after that, we select an appropriate diagnostic test because remember, these are differential diagnosis alone. No? These are the closest diagnosis that we can consider. So, in order for the diagnosis, for the doctor's diagnosis to be definite, of course, the definite specific diagnostic and laboratory test should be performed, such as stool culture, sigmoidoscopy, intestinal biopsy as appropriate. Now the question is, why do pharmacists have to be familiar with this one? Because in along the performance of the different diagnostic test procedures, we also have to monitor and evaluate the possible presence of drug laboratory interactions, which could greatly affect the results of the test, or at the very least, we can also be consulted for the different medications that can be used while the diagnostic tests are being conducted. So, like for example, if they are projecting for a bacterial in cause, doctors can consult pharmacists on their suggestion or recommendation on the updated preferred antimicrobials, empiric antimicrobials that can be used while awaiting the results of the culture and sensitivity. So, so from this, after we perform after they have performed the diagnostic test, if there's no diagnosis or definite diagnosis, symptomatic therapy can be induced. While if there's a diagnosis, a confirmed diagnosis, treat it specifically. So again, the primary or the drug of choice for diarrhea of unknown cause or known cause would be to provide ORS, because what we would like to prevent is dehydration. And dehydration is very deadly or to um, special populations, and dehydration can predispose mortality to patients. Now, for the anti-diarrheal preparations, we have a lot of medications that we can select from. We have anti-motility, such as the diphenoxylate, loperamide, paregoric, opium tincture, and diphenoxin. Although here in the Philippines, commonly we are familiar with diphenoxylate and loperamide. For adsorbents, we do have our choline pectin mixture, polycarbopyl. We have atopulgite. Sorry, it was covered by the logo. So for choline pectin mixture, normally pectin, if you can remember in your pharmacognosy, this can be extracted from apple, right? So they act as adsorbents. So meaning to say, they absorb the chemical or the causative agent for the diarrhea. And then we can also have anti-secretory in the form of bismuth subsalicylate. Uh, growing popularity are the use of enzymes or lactase. This is normally done, especially if the diarrhea is related to lactose intolerance. And then we also have now the use of bacterial replacement or the probiotics in the form of lactobacillus, Acidophilus, and Bulgaricus. We also have now what's the brand of this? Sorry to mention, it's Ursiflora, but Bacillus clausii, no? So that's the generic. We also have octreotide as another drug. So I will not be indulging much discussion on these drugs. Although what we have to note is for the adsorbents in other countries, popular options are the opiates and opiate derivatives. So their main action is to delay the transit of intraluminal content or increase the gut capacity, prolonging contact and absorption. So that would limit now the diarrhea. Normally, the limitation of opiates is, of course, we know that it has addicting potential. So that's why it is not advisable to use the opiates readily or abruptly. Now we also have loperamide. It is often recommended for managing acute and chronic diarrhea. So if what we have to take note, if for example the diarrhea after initiating loperamide would still persist until 48 hours, that would already warrant medical attention. So adsorbents are mainly for symptomatic relief. No, basically they don't have specific mechanism, and aside from they absorb the toxins, the drugs, or digestive juices that are contributory to the diarrhea. For the bismuth and subsalicylate, so this is used to treat or prevent diarrhea. In most cases, what we have the traveler's diarrhea, since bismuth subsalicylate has anti-secretory, anti-inflammatory, and antibacterial effects. For lactobacillus, again, these are the intention of this is to replace the colonic microflora. No? So they are probiotics in nature. And then in other cases, we also have anticholinergic drugs such as atropine. The purpose of that is for vagal tone, to block the vagal tone and prolong gut transit time. However, since we know that atropine has certain side effects, and this is considered a controlled substance. So we limits its it limits the use of atropine with diarrhea. And then for octreotide, this is a synthetic octapeptide analog of somatostatin. And this is normally prescribed for symptomatic treatment of carcinoid tumors and other peptide secreting tumors. So for adverse effects, it can cause cholelithiasis, also diarrhea and abdominal pain. Here in the Philippines, we also have one option. We have Riscadotril. So this is a drug that helps aids in the treatment of acute diarrhea. So popular options for here in the Philippines are the use of antibiotics, Riscadotril, and probiotics. But then again, these medications should be prescribed. So patients should be carefully assessed of the cause of the diarrhea so that appropriate treatment can be given. So for the evaluation of therapeutic outcomes, the constitutional symptoms usually improve within 24 to 72 hours. Again, to take note, if upon initiation of course of, like for example, an adsorbent or a loperamide and still symptoms persist, consultation should be provided. The frequency and character of bowel movement should be checked each day along with the vital signs and improving appetite. Monitoring of body weight, serum osmolality, electrolytes, CBC, urinalysis culture, especially if infectious in nature. With an urgent emergency, any chance in the volume status of patient is the most important outcome. So, meaning to say that one of our intention is to prevent dehydration. And toxic patients, those with fever, dehydration, and hematochezia, and those who are hypotensive do require hospitalization. Okay, that's all. Thank you. And here are our references.